Thank you so much, sir, for nice words. It's my pleasure to present our work, departmental work in this field that we are doing for the last 10 years. Uh, Before I go to my specific publications, I will just like to present the three slides which drive us for research in this area. So as Dr. Jabbar has said that the prevalence of gestational diabetes has tremendously increased. And this slide shows that 1 in 6 pregnancies are affected by the hyperglycemia in pregnancy. And when you see the Southeast Asia is nearly 1 in 4 pregnancies are affected by the hyperglycemia in pregnancies, and 80 to 90% are contributed by the gestational diabetes. So this is a huge load for the South Asian subcontinent that we see in our region. The second major thing, you are all aware that the gestational diabetes mellitus is associated with the adverse maternal and the neonatal outcomes. But what the less investigated field is a postpartum uh, uh, after the childbirth, which, and this study showed that even in the postpartum field, the risk is not low. In this, it reflects that the women with a gestational diabetes are at 10 times higher risk for developing type 2 diabetes in future as compared to the normoglycemic partner, which is a huge load in these young women. And this data again reflect that the distribution of risk is not equal in the regions. The risk for GDM is high in the South Asian, and so is the prevalence of conversion to type 2 diabetes after pregnancy is also very high. This is a data from the Canada in which they have compared the different ethnicities, and as you can see that the risk is greatly higher for the South Asian women as compared to the Chinese or the white women for the development of type 2 diabetes. So these are the three things from the public health significance, the disproportionate risk that is seen in the South Asians, which make us to work for to generate research data in this field for the last 10 years. So my basic plan is to present a thematic view on the observational data in which we evaluated the hyperglycemia risk in these women and the burden of the cardiometabolic risk factors along with this assessment of the hyperglycemia. I will show you a couple of studies that we are doing for the intervention part, means for the prevention from pre-diabetes to type 2 diabetes or from normoglycemia to pre-diabetes. And there is a little bit extension of our work for the last couple of years to the family part, and we have evaluated the spousal risk along with the women. And there is some peep into the other areas also, which I will briefly touch in my presentation. So my focus of this presentation is not to present too much data from our study, but what I will do is just give you a salient overview of each study, what we learned from each one, and how we linked and formulated the another study based on our learning from the previous one. So this work started when I was doing my DM dissertation in 2010, when Professor Nikhil Tandon allotted me this thesis, the conversion of gestational diabetes to future type 2 diabetes mellitus, which we initiated in 2010. And as you are aware that we are now having IADPSG criteria for diagnosis of gestational diabetes, but before 2010, it was the Carpenter and Couston criteria, which was more prevalent at the time. So when we initiated this work, it was basically with the women who were diagnosed with the gestational diabetes using this Carpenter and Couston criteria. The data was very limited from Indian subcontinent. And as you can see, there were only 2 studies when we formulated this study, and there was only a handful of patients that were evaluated. But what was remarkable from this data, that it was clearly a high prevalence of type 2 diabetes that was seen in the women, like 1 in 2 women converting to type 2 diabetes within 5 years of giving a childbirth. So this was remarkably high and compared to the other ethnicities and the data in South Asian seen in the other regions. So these are the main findings in which we evaluated 366 women. We took from Hyderabad and Delhi. The postpartum screening response was 37%. What we saw that the figures of type 2 diabetes was surprisingly high, 32%. And there were 40% of women who were pre-diabetes, means nearly 3 out of 4 women had either diabetes or pre-diabetes at a mean age of 30 years, which is too young for these ladies, and the burden is too high for them. What was more interesting that 1 out of 2 women developed type 2 diabetes after 2 to 4 within 2 to 4 years. I mean, it is even earlier as compared to what was seen in the earlier studies at a mean age of 5 years. What we saw that similar rates existed at less than 4 years. We did not have a control group in this study, but when we compared the data from the population-based research from Delhi and the Chennai centers, so it was surprisingly very, very high, 18-fold excess risk as compared to the women who were within 20 to 29 years, and it was 30 to 30, it was nearly 10-fold excess risk in the women who are 30 to 39 years. So this was surprisingly high and confirmed the previous findings. But what was remarkable is that the conversion rate happening at very less time after the childbirth. And this slide, I just want to highlight, this is not surprising that this is a meta-analysis published recently. What I showed is an 18-fold high risk. This is what the 2020 meta-analysis confirmed it, that the younger women has 18-fold higher risk as compared to the normoglycemic partners to develop type 2 diabetes. And what I showed 9-fold higher risk in 2016. This 220 meta-analysis suggests the similar finding, 9 to 10-fold higher risk as the women are older. So the another surprising part is that despite having higher risk in these women, the postpartum screening rates are very, very disappointing. In the routine clinical practice, I will say it is not even 10%. We try to target and contact each woman who delivered in 5 years prior to enrollment. And even despite our best effort in the research settings, we were able to contact and investigate only 35% of the women. So you can just see how difficult the problem is, that means most of the women will continue with the undiagnosed diabetes in the postpartum period. So what we learned from this study was the highest rates. This study reported the highest ever in the literature within 5 years of follow-up after childbirth. And what we learned that if any efforts has to be put for these women to reduce the development of diabetes, it should be early, and preferably it should be earlier than 2 years, because most of the women will convert to type 2 diabetes within 2 to 4 years. But as we learned from this one, the criteria changed from Carpenter and Couston to IADPSC criteria. So the findings could not be extrapolated to this IADPSC criteria, because in our cohort, 70% of the women diagnosed with the Carpenter and Couston criteria were on insulin therapy. Whereas we know that typically the women diagnosed with the IADPSC criteria, only 20 to 31% women typically require insulin. So these are clearly at low risk, and the similar figures cannot be extrapolated to these women. So this created a knowledge gap to generate data with the IAT-PSG. And before planning the next study, when we looked into the literature, there were only 2 studies available before we initiated the next work, and which suggested the prevalence of diabetes is low, what we found with the Carpenter and Couston criteria, but the dysglycemia rates were high. Nearly 10% reported by Dr. Mohan from Chennai for type 2 diabetes, and nearly 38% reported for the women who were investigated before 1 year of their childbirth, after 1 year of their childbirth. So the rates for dysglycemia were pretty high in these women. So, but there was no long-term data that was available on these women diagnosed with the IADPSC criteria when we allotted another DM dissertation in 2015 to look for the long-term postpartum glucose tolerance status in these women diagnosed with the IADPSC criteria. So what we found that the diabetes rates were 10.5%. It is nearly the same what Dr. Mohan reported from Chennai, and the rates are from Delhi Center. And what was surprisingly that pre-diabetes rate was high. Only 4 out of 10 women were normoglycemia with the so-called IADPSC criteria, which is known to pick the milder cases. And these figures of 60% dysglycemia are surprisingly high for this sort of criteria. What is also important is to know the burden of the other cardiometabolic risk factors. Nearly 2 out of 3 women are overweight and obese diagnosed with this criteria. And the metabolic syndrome was present in 40% of the women, 10% of the women having hypertension, another 40% having dyslipidemia. So the burden of hyperglycemia is high, and along with that, the burden of other cardiometabolic risk factors is also high in this young women. The data was published in May 2018, and 4 months later, we had the follow-up data from the HAPO study. You must be aware regarding the HAPO study, which gave us the IADPSC criteria. The follow-up was reported at a median of 11.4 years in the HAPO study in September 2018. And what was interesting to see was that even we were a decade lower as compared to the HAPO1. Evaluated patients in less than 2 years postpartum. The median interval follow-up in our study was 1.6 as compared to the 11.4. But what you can see is, interestingly, the similar rates of diabetes in the HAPO study as compared to the South Asian study. I want to reinforce a point that HAPO study did not include any South Asian country in their study part. So the data again could not be reflected or extrapolated from them to the South Asian part. So the pre-diabetes rate with using the similar criteria as used in the HAPO, we were having 33%. So the 10 years younger patients, similar rate of type 2 diabetes, peak of the volumes or the burden that we see in the South Asian country. Again, there was some limitation of our study because AIIMS is a tertiary care center. So we felt that it may be due to the referral bias that we have high risk women enrolled in our center, and the data may be biased due to this part. But fortunately, what we have now, the baseline assessment, I will be talking regarding this trial, which is again the biggest trial in so far in the postpartum period for the prevention of diabetes, which we are implementing in the South Asian countries, and we'll talk more about later. But what the baseline assessment from this trial has shown, that this trial basically is getting implemented in Bangladesh, Sri Lanka, and India with 19 centers across these 3 nations. And what you can see is that the type 2 diabetes rate is 9%, what we generated from a single center. The similar rates are being reflected across the South Asian continent. And the pre-diabetes rate is 33%. I mean, the similar rates, what we found in the single center study in from Delhi, are being reciprocated from the multi-center study across the South Asian. What is surprisingly means figures for us is that in the IDF compilation, the India is said to have a higher prevalence of GDM as compared to the Sri Lanka and Bangladesh. But what we see is the type 2 diabetes rates are higher in Bangladesh, followed by Sri Lanka, and it is lower in India. And we are looking into this data to see what are the reasons for these differences. But what it reinforces is that all countries in South Asia face this similar burden of cardiometabolic risk factors. And again, you can see 73% of the women overweight and obese. When I say overweight and obese, this means the BMI greater than 25 kg per meter square. To summarize my observational part from these 3 studies that we did, is that the prevalence of diabetes and pre-diabetes is high and is seen within 2 years of childbirth. We analyze the follow-up data. We are following this cohort prospectively, and in a process of writing the paper. But to give you some more insights, that the women with the pre-diabetes, out of every 10, 3 convert to diabetes at a follow-up of 2 years. Again, the conversion rates are very, very high for these women at a younger age, and there is need for the prevention studies. So in 2010, while we did some observational work, we again implemented some prevention part also. This was a pilot study which was funded by the IDF Bridges under with the grant recipient being the Dr. Nikhil Tandon. Again, this was part of my DM dissertation at this time. So we enrolled women from this observational cohort that we evaluated. And the aim of this intervention part was basically to formulate the intervention package and evaluate the feasibility and its potential effectiveness for these young women. We recruited 56 women from Hyderabad and Delhi without diabetes and delivered the intervention over 6 months in 4 groups of 12 to 15 women each. In this intervention package, there were 2 sessions on diet and nutrition. There was an introductory session in which we interacted, gave an overview of the intervention program. There was a session taken by the mental health specialist on stress and sleep, and there was a session on the physical activity and a wrap-up session at the end of 6 months. We did a pre and post intervention. This was a non-randomized study, and after 6 months, we assessed the metabolic parameters and used the GTT for the glycemic assessment. What was encouraging for us was that 70% of the women reverted to normoglycemia that were pre-diabetes. This is a huge success rate from the intervention part, and it has practical implications from a public health point of view. What was also encouraging that 50% of the parameters that we evaluated significantly improved after the intervention. Another learning point was that intervention was feasible because 80% of the women attended 4 or more than 4 sessions out of the 6 months. There was a receptibility for this intervention parameters. So based on this pilot study, we were funded with a large grant by the Global Alliance for Chronic Diseases. This is in collaboration with the Australian investigators and Sri Lankan Bangladesh investigators. This is the largest trial so far in this field and akin to DPP, Diabetes Prevention Program, in which we are enrolling 5 times greater population of GDM as compared to the Diabetes Prevention Program in this trial. This is an open label parallel group pragmatic individual randomized control trial in which we are delivering the low intensity lifestyle modification program in 1,616 women with a prior GDM to be recruited from 19 hospitals from Bangladesh, India, and Sri Lanka. And the primary outcome is a change in the glycemic category, and there are secondary outcomes which will evaluate a number of metabolic parameters. This is a spread of the sites from Chandigarh, Delhi, Mumbai, Chennai, Hyderabad, Goa, and 4 sites from Dhaka, and there are 5 sites from Colombo. So this is a pan-Asian study. Just to give you a silent glimpse, because of this trial, that in this trial we identified 3,500 women of GDM during pregnancy, and evaluated 1,800 of them during the postpartum period, out of which we randomized 1,616 women to the intervention of the control arm. The recruitment of this trial has finished in December 2019, and we are basically wrapping up the final visits to be completed in Jan 2021, and we will out with the results of this trial next year, which will show or suggested what the lifestyle intervention program has to offer for these young women. So the intervention program in this trial is basically comprised of 4 intervention sessions, group sessions, multiple phone calls, a package of 84 SMS, and the individualized session depending upon the need for the women who needs a sort of intensification of the intervention program. What I want to highlight, and which is important for the researchers, is that in initial 2 studies, we were not aware why the postpartum screening rates are low. This study, in which systematically collected the data, and we found that 25% of the women have wrong details entered in the hospital records, which prohibit from getting into contact with them. The refusal rates are typically 25%, but there are other issues which need to be tackled if we want to improve the participation in the research programs. We conducted in-depth interviews as part of Living program with the endocrinologist, other healthcare staff, and the women with GDM. What we found is that number of factors, but what I want to highlight is that the women like the family members to be involved in the intervention program. And there are 3 reasons practically for that. One is a logistic, because South Asian women feel difficult to come to the sites alone. Second is intellectual. They may feel more confident that if they are not able to assimilate the knowledge, what is being given, so there is some member who can get that sort of knowledge. Third is a motivation or emotional support, because once you taught, they have to be sustained. And the family members can act as a motivating factor in the long run for sustainability of intervention. And the best family member to get involved is their spouses. So we were getting some insights from our observational data, and after interviewing a lot of participants, this got reinforcement this part. And taking this part forward, we did a study to evaluate the glycemic and the cardiometabolic burdens on their spouses. This is a first study that has been published in Diabetologia, in which we evaluated the spouses of the women who were having prior GDM. We know that GDM is a high risk entity, and there is cardiometabolic burdens ought to increase in these women. But surprisingly, what we found is that dysglycemia rates is equally high in the men. Overweight obesity 63% in men, 66.8% in the women with the prior GDM. Metabolic syndrome rates are higher. So the most of the attention is the women with the prior GDM, but the men also show the equal prevalence of the cardiometabolic risk factors. When we look about the concordance, 1 in 3 couples had dysglycemia. 33% of the couples, both partners had dysglycemia. 1 in 2 couples, both partners had overweight and obesity, and 1 in 4 had metabolic syndrome. So there is a high degree of concordance in the spouses for the cardiometabolic risk factors. And 8 out of 10 men that we evaluated had one of this cardiometabolic risk factor. This means that equally the men also stands at high risk for cardiometabolic risk factors, and the prevention strategy needs to be developed for their spouses also. What we interestingly also found that the women who had a partner with a dysglycemia, tend to have a higher BMI, higher waist circumference, higher diastolic blood pressure, higher HDL, the metabolic syndrome, and dysglycemia rates. Means the dysglycemia present in their spouses affects their status of the cardiometabolic risk factors. So the involvement of spouses is not important for just for motivational sport, but is also important from the intervention point of view. We did a validation study in the assessing the spouses in women who were pregnant at the time of pregnant, a cohort which is 4 years younger than the previous cohort. And surprisingly, the similar sort of figures are being reflected from this study also around the burden of the cardiometabolic risk factors, again 60%, 50% in these spouses. So this reinforces that along with the women, it is important to focus on the men, because most of them will accompany them in the hospital visit or after in the postpartum screening period. To summarizing this part of my presentation, there is a high rates of conversion to pre-diabetes or type 2 diabetes after GDM in Indian women, but there is equally high burden or spousal concordance of the cardiovascular risk factors. So we talk about the universal screening for the women during pregnancies, and we talk about the screening for women with a prior GDM in the postpartum period. But what we are learning is that the spouses are equally need to be involved with them. So based on this learning, what message we gave in the diabetology paper is that high degree of spousal concordance suggests the need for family intervention trials that involve the spouse as a target of intervention and not merely a sportive partner, the point that has been advocated by the many groups. So based on our work, we have been recently funded as from the AIIMS, has a Center of Excellence for Advanced Research in this field, in which we will be testing this hypothesis, whether the involvement of spouses make a difference for them or not. We will be randomizing the women along with spouse or women alone to the intervention part, in which we will be testing, giving the 4 group session and 4 individual sessions. And the research question that is that will involvement of the spouse enhance the effectiveness of intervention for women, or will intervention targeted for women help spouse in addition to the women? So looking from a monocentric women's approach, we are trying to take out the attention of focusing more on the family sort of stuff. We did some work in the field of women. We did a couple of studies in assessment of the spouses, and now we're extending it to the family cohort. Again, this will be the first South Asian cohort which will be evaluating the offspring in the long-term basis for these women, and see how the family cardiometabolic factors interact with the offspring cardiometabolic risk factors. I will not go deep in the interest of time in the another studies, but now it's also point to get into the other fields. We assess the non-alcoholic fatty liver disease. Again, this is a first study which has been done by the AIIMS criteria, in which we evaluated 200 women with a prior GDM. And surprisingly, what we found is a high rates of NFLD in these women. 62% has compared to the 38 to 48% reported in the previous studies, which has been done by the other criteria. So there is not only the high burden of cardiometabolic risk factors, but again, the status of other organs is also burden is high in these young women. Just a slide on a work during pregnancy, in which we did a continuous glucose monitoring system assessment of the glycemic status, and this is our first study to generate the normative data in the early pregnancy using AIIMS criteria. We'll not go into detail in this part, but for the youngsters who are listening, the data, it's basically 2 standard deviation plus the mean, which sets the norms for this younger population. To summarize my presentation and the 10-year journey that we have been in this field, we started in year 2010, when we know that GDM women had 8-fold higher risk of diabetes from the meta-analysis published in 2019. We had information that South Asian manifest diabetes early. We did a first study to demonstrate that high risk of type 2 diabetes at very early postpartum period, never reported in the literature so far, and consistently shown by 3 of our studies. We did the first intervention study in 2010 in South Asian women with a prior GDM, which helped in getting us a 10 CR grant from the JACD. In 2015, the criteria changed. So there was a change in criteria for GDM diagnosis, and there was a need for new study. And we reported the first long-term data on the postpartum glucose tolerance and cardiometabolic risk factors in women diagnosed by the IAD-PHG criteria. And now we are following up this cohort and will be reporting the incident data soon. We spread our work to these spouses when we showed that the cardiometabolic risk factors are high in these spouses, and it needs to be a family-centric approach rather than the monocentric approach. This is a trial in which we will be reporting the data in 2021 on the intervention part in the last South Asian population. We extended in work in 2017 to other areas in which we assessed the status of NFLD and found that the NFLD status is very high, prevalence is very high in these young women. We are stepping into some technology and in the pregnancy part, and will be generating some more papers on this normoglycemic norms in pregnancy. In year 2010, we have been granted by the AIIMS with this grant, in which we'll be extending to our work to the full family of these women. So my sincere thanks to the collaborators in the Department of Endocrinology, especially my mentor, Professor Nikhil Tandon. There are a host of collaborators from the multiple countries. In interest of time, will not take to list each of them, one of them, but this shows
We are, to just to interrupt you, we are already running 12 minutes.
Yeah, thank you so much.